Before we start, for the participants who wish to hear this presentation in English, look for an icon on your screen that says Interpretation. Click on the icon and choose English. If you don't see the icon,
Antes de,
the cursor on the bottom of the screen and that toolbar with the icon should appear. We recommend that you mute the original audio to better hear the interpretation. I will repeat this in Spanish. Para quien desea escuchar la presentación en inglés, busquen un icono en su pantalla que dice Interpretación. Cliquen y seleccionen Inglés. Recomendamos silenciar el sonido original para escuchar mejor la interpretación.
For those of you who would like to listen to the presentation in English, just look at the bottom of your screen and click on the globe icon, selecting interpretation and then English. Good morning to all of you. Welcome to the Continuity for Home Care and Telecare Services, Continuity for Elderly People within the COVID-19 framework, co-organized by the Inter-American Development Bank, the French Development Agency, as well as the European Union through its Euro-Social program, as well as the Central American's Social Integration Secretariat. This webinar is part of a dedicated series to provide support to Latin American and Caribbean countries to mitigate the impact on COVID-19 on elderly persons. And it's part of the series of seminars that we are conducting online related to the aging landscape and care for dependent people, sponsored by the Inter-American Development Bank, a series in which regional and international experts share their insights about the design, implementation, and evaluation of care systems for dependent people. As I mentioned in the first webinar related to this subject, this initiative is a first step in the creation of a regional network on caregiving policies in Latin America and the Caribbean, supported by the IDB, AFD, and Euro-Social Plus. The network will be integrated by the institutions that formulate these policies for care in each country, and it will share their methodology of work in different spaces. Caregiving for dependent people in the home through home care or telecare services is a recommended practice for its positive effects that it provides in terms of the quality of life for the people that receive the services. Additionally, within the framework of care policies, it allows for a reduction in the pressure to the health sector, as well as the residential centers, and it allows for a better redistribution of the resources. So the question is, how can we guarantee continuity of services for home care, avoiding the propagation of the infection and affording people who receive care the physical and emotional benefits that are derived from them? Will these telecare services that have been generated in recent years to provide care for dependency people or people with dependencies be able to be integrated to guarantee this care? So I'd like to yield the floor now to Maria Antonia Calvo Puerta. Good morning to all of you. I don't think you can see me because my video signal is not working. So good morning to all of the participants joining us from Latin America and the Caribbean. And good afternoon to some of our European colleagues. Esteemed panelists and esteemed participants, it's a real pleasure for me to take part in this second webinar coordinated by the European Union through its network system, and also coordinated by the Social Coordination Secretariat in Central America, the Inter-American Development Bank, and the French Development Agency. I'd like to begin by thanking each and every one of them. And this is a key moment for us to undertake these various exchanges among countries in terms of public policy related to providing care for people who suffer from dependency issues. The first meeting was conducted in April, and it focused on home care services. This was a subject that attracted a great deal of interest and participation. And at that meeting, we had more than 500 people in attendance. So we concluded that homes are one of the principal focal points for contagion in all the countries. And we discussed the best measures to afford the best quality of life conditions for elderly people. The situation that we're dealing with at the present time and the topic that will dominate our discussion today relates to home care and telecare for people. This is a pillar that allows us to provide a positive impact in the lives of people who suffer from dependency. And it also minimizes the pressure on health organizations, and it also allows for a more effective use of resources, including financial resources. This is something that affects both our continents. In the European Union, when faced with the aging of the population, when faced with the provision of care services for members of our families, we needed to make sure that we reinforced the systems that provide these services. So we needed to implement the telecare services in those cases where it was deemed necessary. Nevertheless, the pandemic has represented an unprecedented challenge for these services, both for the people that provide services as well as the people that receive services. And these are all people that have had to face these situations. This webinar seeks to exchange good practices and insights and examine the different approaches being employed in different countries in Europe, as well as the Latin American Caribbean region. And so we need to discuss how we can continue to provide these services to people who are homebound and who are dependent. So we need to consider that the state of well-being is a fundamental factor in Europe to be able to address these issues. We have a social pact that focuses on this welfare, and it needs to be supported by solid policies. It's part of the philosophy of the 2030 agenda to leave no one behind. We need to provide care to the most vulnerable groups. Several of our partners have met to address this initiative, and this is the core subject that we will be discussing today. This is in line with the agenda in the European Union, which is also part of the response to the COVID-19 pandemic. I'd also like to extend a very cordial greeting to Mr. Alfredo Suarez Meses. And he represents an institution that's part of the European Union. He has been involved in a series of exchanges in the Latin American and Caribbean region, particularly in the Dominican Republic, and worked extensively on policy geared towards strengthening the caregiving systems in those countries. Lastly, I'd like to thank the organizers of this national care network, the IDB and the AFD, who have been working in a joint fashion. And we believe that this initiative is a strong one, and we believe very, very much in it. We believe that we can launch this network and subsequently continue these meetings to be able to strengthen our efforts, both in virtual meetings as well as in in-person meetings. Given the climate of uncertainty that we are facing at the present time, something that's very clear to all of us is that we need to share all of these topics related to inequality, and we need to also share the solutions that we are bringing forth to address these inequalities, and we need to work together to try to overcome these issues. Thank you very much. Thank you, Dennis. Today we have the honor to be joined by Juan Luis Bermudez, Minister of Human Development and Social Inclusion and President of the Instituto Mixto de Ayuda Social from Costa Rica, who will be presenting on the Costa Rican experience, which has been lauded as one of the best in the region for containing the pandemic. Likewise, we also have the honor of having Daniel Radío, Director of the National Care System from the Social Development Ministry in Uruguay. Daniel will speak to us about the measures adopted by Uruguay to provide care to elderly persons in Uruguay through home care and telecare services. It's also a pleasure for me to introduce Alfonso Lara Montero, Executive Director of the European Social Network, who will discuss some of the measures adopted in some European countries to reduce the risk of infection in the provision of services in the home. The debate will be moderated by Lourdes Bermejo, Vice President of the Spanish Society for Gerontology and Geriatrics, and who was also with us during the first webinar. Additionally, we will have the participation by representatives from other countries in Latin America and the Caribbean Union, as well as Europe, and we will open the floor for comments and questions. The webinar will have a duration of 2 hours. Presentations will last for a total of 30 minutes, and they will be followed by 20 minutes of dialogue and discussion, and we will then subsequently open the floor for questions and answers. At the end, we will set aside some time for conclusions and closing. As a courtesy, we have silenced your microphones. We invite you to submit your questions and your suggestions at any time through the chat room in Zoom. We'd like for this webinar to be truly participative, so please do not hesitate to submit your questions or comments. Please use these options and direct your comments to everyone so that everyone can be informed about your question or your comment. Before I yield the floor to the presenters, I'd like to thank the followers of our website regarding the landscape and the Eurosocial site dedicated to the COVID-19 pandemic, and invite the public who do not know about it to start following us. Lourdes, you have the floor. Thank you very much for this opportunity that you've provided to me to share some insights and to moderate this debate that relates to care services being provided to elderly people who suffer from dependency issues, and frame this within the COVID-19 pandemic. We also have representatives from the Latin American and Caribbean countries, as well as Europe. I will be first and foremost yielding the floor to each one of the panelists that we've invited. Each one will have 10 minutes maximum to make their presentation. So when we get to the 9-minute point, I will signal to you that you have 1 minute left in your time. I think we need to be very rigorous in the application of the timeline so that we ensure that we don't go past the allotted time. So with that, I will yield the floor to Juan Luis Bermudez, Minister of Social Development in Costa Rica, to share the Costa Rican presentation as well as the experience. Good morning to everyone. And first and foremost, I wanted to thank the Inter-American Development Bank, the French Development Agency, and other organizations for putting together this meeting to address this very relevant topic. The pandemic has not only obliged us to consider strengthening our social services infrastructure, but it also affords us the opportunity to improve our health services. And we need to do so at different levels in the entire structure of the system. So given such a complex situation, which is what we are facing in a region that has so much inequality, we need to discuss these initiatives and mechanisms to try and provide greater inclusion for our population to the subset of rights that define them as human beings. So it's a real pleasure for me to present some of our interactions that we undertake in our comprehensive and precise care provision system for elderly people in the face of the national emergency due to the COVID-19 virus. So we include risk management issues. We also include the participation of the National Association for the Elderly, our social security system, which is both a financial institution and also a provider of services in our entire country. They provide a number of social services as well as other organizations, including the National Council on the Elderly, and we also work extensively with Teresita Aguilar. And taking into account all of these health measures, these are organizations that have been at the forefront of trying to adopt all these measures. I'd like to provide you with some basic information regarding the status of our caregiving services directed to the elderly at the present time. Our country is small. We only have 5 million inhabitants, and older people represent approximately 11% of the total population. We have a very high disease load of non-communicable diseases. So far, we've had 863 confirmed cases of the COVID infection. 43 of those are represented by members who are elderly. We've had a number of people recover. 10 people have died. Most of the ones who have died ranged in ages from 47 to 77 years of age. This is our summary of the actual numbers. And what is it that we've done to address this situation? Well, we've tried to attach or apply 3 different approaches. One of them involves communication that is heavily directed towards the population based on their habits and preferences. We have communications that are based on the origin of our population. We have a number of members of our elderly population that do have some intervention on social media, but most of them do not. And so when we consider different cultural aspects as well as other aspects, it becomes necessary for us to engage in our communication efforts through different media, which includes radio stations, television stations, as well as online applications. And this is done in order to ensure proper treatment for all of our people. And we've also tried to come up with a directed health intervention that focuses on the elderly. And I'm going to be showing you some slides that relate to that particular part of our program in just a few minutes. Next slide, please. Our communication strategy seeks to create awareness among the elderly, but not just them. rather also their support networks, be they their immediate family members or other communities where they may reside. And the idea would be to provide information related to the psychosocial care services as well as conditions that they're living in, health conditions that they're living in their lockdown condition or homebound condition. And all of this includes consideration for the closeness that they may be experiencing with their family members at home. So the campaign was directed not only at the elderly, but their surrounding social support network that includes the immediate family members. And so we have to profile the messages in a certain way to really try and create this awareness among these different populations. In terms of the care services that are being provided, this is just a summary. In our country, nationwide, we came together through a technical task force that addresses emergency situations. We've divided the work into three different branches. Much of the work is directed to the elderly, but we have other services. There are some services that are afforded to elderly people before they are impacted by the COVID-19 pandemic. And a lot of these focus on health conditions, and we're trying to ensure that medication is provided in a timely way. So we have our postal services delivering medication to the door of these homes so that we can minimize any exposure. We also include other health practices and even emergency services. We also conduct extensive home visits, and this allows us to have a more adequate control both for the personnel that's providing the care as well as the people receiving the care, because if we can detect any suspicious cases or confirmed cases, then we can then deal with these cases in an immediate way. We've already seen recently, just last week, a case in which we had a patient that had left the healthcare facility, went back home, and thanks to the monitoring that we provided as a follow-up to this person, we were able to confirm that person's condition over some period of time by providing some follow-up services, and this allowed us to avoid any type of contagion within the home. So during these last few months, we've provided extensive information to people in the general public so that they could avoid these types of situations. And we prioritize these patients to ensure that these services are capitalized to the maximum extent possible. We also have some resources as part of our social protection system, and they're not only limited, but the typical sources that we see for these situations have been changed, and in some way we have needed to adapt to these changes. And when we talk about healthcare services, there's some more detail on this slide. One of the things that we have is EBI's basic integrated health teams that are equipped with a physician, a nurse, and an administrative staff member. And these are the people that control the documentation. Luis, you have 1 minute left. If you can please conclude. So the primary care technicians can provide services telephonically, and they can also provide care in different ways. And the socio-sanitary approach is basically broken down as follows. We try to get the information that we have in our national database that covers 80% of the population, and we combine this with the EDUS, which is the health database, and this allowed us to collate both databases and identified the higher risk elderly or older adults that could be vulnerable. And I just wanted to show you the last slide, and we defined 3 priority groups, which at the present time are subject to follow-up services as well as caregiving services. And that's what we've done as a country, and we thank you for your attention, and we're more than happy to answer any questions. Thank you. Thank you very much, Juan Luis, for your capacity to shorten your presentation and to meet the time allotment requirements. Before we yield the floor to our next participant, I'd like to ask participants that when you submit your questions, please ensure that you include who your question is directed to. Thank you. Well, now we have Mr. Daniel Radío.
We're now going to hear from Mr.
National
Radío from Uruguay, and he's going to be telling us about the
caregiving
experience in that
system
country. So, Daniel
director in
Radío, you
Uruguay.
have the floor.
You have the floor, sir.
Good morning. Can you hear me? Yes, we hear you quite well. Thank you. First of all, I wanted to thank Eurosocial and the Inter-American Development Bank for their kind invitation to invite the Secretariat of Uruguay to take part in this. It's important that we discuss these issues. This is important in dealing with the pandemic that was upon us by surprise and suddenly. So it's important that we all think of these different ingredients as we make decisions in our countries. I don't know if you can show my presentation on the screen. Now, perhaps we can move on to the next slide. So I'm going to make some statements where we have to remember that all empirical evidence shows that the elderly are more prone to develop more complex symptoms of the disease just because of the aging process, plus the greater presence of comorbidities. And these people mean that these people are at risk in this pandemic. So in this context, it's especially important that we take measures to deal with this. And this health emergency has set off some yellow lights for all of us as we think of policy in our countries in the long term. Now, in dealing with these services, you should remember that in Uruguay we have 2 types of home programs, and that is what I'm going to cover in my presentation. We have personal assistance, and also we have home assistance services. So here on this next slide, I'm going to tell you about the personal assistance. Here you can see Flor. She uses our programs, and this is Nacho, and he is a personal assistant. And so people that are in a situation of severe dependency, they have access to services. They need important support so as to be able to fulfill basic needs and to be able to carry out basic activities of daily living. Now, there's a mistake on this slide. It's exactly the opposite. It is for people over the age of 80 and under the age of 29. That means that people can get personal assistance provided by people that have been trained in our National Comprehensive Service Framework. And there is a determination of need, and this service provides assistance and support in performing activities of daily living, always within the framework of promoting autonomy. We provide this service to people over the age of 80. And the objective of this program is to promote access to quality care for people who are in a condition of severe dependency. They receive those services at home. The program aims at contributing to equity in access of people who are in a situation of severe dependency so that they can perform the daily activities of living. And also, the users help contribute to the work done by the person that deals with that individual in her or his home. And most of these assistants are women, and the idea is to improve the labor characteristics of people that work as personal assistants, also to guarantee assurances for these people. Let's move on to the next slide. And specifically, what were the actions that were taken in our country regarding this program as part of this health emergency? First of all, in the Secretariat, we designed materials for the people that work as personal assistants with a view to supporting the work of personal assistants to assure the quality of the care given to the elderly. And this includes prevention activities and performing the task so as to not spread the virus and to assure social distancing. These materials were prepared to promote the physical and emotional well-being of the elderly without minimizing the feelings that might emerge. Also, the recommendations say that personal assistants need to generate tools so as to best perform their task and deal with the stress that occurs in this new situation. And also so that the elderly will feel that they are accompanied. Also, we looked at risk analysis, we did flu vaccination, we made elements to prevent against contagion. That would be alcohol gels, gloves, etc. And we gave priority to these workers. We gave them training regarding prevention measures that was offered by the Ministry of Public Health. And also there were periodic communications having to do with creating a mindfulness of the work done by these people. Another thing that we tried to do was we looked at how we are dealing with a change in routine. And through the social networks, we made an appeal looking for people that wanted to share this experience. And these recommendations are being gathered. The idea is to have a compendium of how to deal with this health emergency. And you can probably find that on our web page along with other social networks. Here in this next slide, we have Angelica. Angelica is one of our most famous users. I wanted to tell you about the other service that we provide, and that is the home tele-assistance or remote assistance service. And in that way, people that have a slight or moderate dependency, they can get access to timely assistance if they're having problems at home, if they need the support of a third party. The person has a terminal at home. It's connected to a care center. It is activated by pushing on either a bracelet or a pendant around their neck, and in that way they connect to the care center. What they do is they push on this button that creates an alert, and the alert is connected to a 24/7 care center where they know who the person is, what his history is. The person explains the question they have, and in that way, the contact network is apprised of the situation. Also, we have the support of the Comprehensive Care Center, and this is a system that is subsidized, but the cutoff is 70 years of age. You have to be older to be able to use it. The idea is, as I said, to help people with a slight or moderate dependency. And in that way, they get an immediate consultation. They contact someone that can help them. And in that way, it delays further dependence. Also, in that way, people in a household with slight or moderate dependency can be dealt with. That also reassures these people because they feel that if there is an unexpected situation that arises, they can find help from that center. Now, what have we done in the framework of the health emergency? We agreed with the vendor services that they would provide information for prevention to users and also that they would provide, or we gave recommendations to these vendor services, and also with the remote assistance services, we were able to monitor users, asking them about their mood, their anxieties, their concerns, and increased communications if we detected any symptoms of alarm. Also, there is a lot that can be done to support and reinforce recommendations to maintain routine, to create an alert in exceptional situations. Now, this is a service that, if extended, would create many benefits for the user population, and it would probably also increase the efficiency of the use of healthcare services. In 2019, there was a census taken gathering information about this service, and this is a service that is tremendously important for the user and for their families. It creates a situation of well-being. They know they can count on this service, and people experience an improvement in mood, and they feel that this service has had a favorable influence on their health status. Sorry, I have to interrupt. Yes, we can conclude with the very next slide. Two very brief comments on each of these services. One having to do with the personal assistance. There are some complexities that we need to take note of so as to become mindful of these difficulties and better address the problems, coming up with solutions to provide better services in the context of this current situation. What do I mean? Although this is something we have not quantified, we know that some personal assistants are concerned about their work, thinking that it may affect their own health, the health of their families, and all of these concerns have not been adequately addressed because the users or their families have asked these people to not come to work, or because the worker, him or herself, has preferred to not continue to work. Now, dealing with this emergency is not easy. Often the contract is between the person and the family, and it's important that both parties agree on the conditions for work. But now, in the health emergency, this is yet one more challenge to deal with. And in terms of the coronavirus services, we find that we have an ally in those that provide remote services. They are disseminating recommendations. Also, this provides for quick alerts, monitoring of symptoms. Also, there is support to users, and we do follow-up. All of these actions help maintain social distancing. That is something that we have agreed is the main measure of protection. Plus, it also activates the support network. Thank you very much. Thank you very much, Daniel. Thank you. Yes, I was only going to say that on our web page and on our social networks, you can find additional information that I hope you will find useful. This crisis has generated new challenges for all of us. Thank you. Thank you very much. And thank you for trying to be as brief as possible. Now we are going to hear from Mr. Alfonso Lara, who is the Executive Director of the European Social Network. He will be talking about the experience in Europe. Mr. Alfonso, you have the floor. Good afternoon. Can you hear me? Yes, quite well. I greet you from London. It is 3:30 here. I greet our audience in the Americas and in Europe. Thank you, Lourdes. And I also wanted to thank the Inter-American Development Bank and Eurosocial, as well as CISCA, for their invitation to take part in this online seminar and to support the creation of a network, as Mr. Sampini said. As I was saying, I'm going to present the network that I belong to, Eurosocial Plus, 140 member organizations in 33 countries, and the presentation was prepared with data coming from responses received from members of 8 countries: Belgium, Denmark, Spain, France, Italy, Portugal, Sweden, and the United Kingdom. Now, we have been asked to answer 3 questions. The first one is, how have we assured the continuity of home care? And what have our prioritization criteria been in COVID? The answers that we got was that the continuity was assured according to 3 criteria. First of all, the people that have the highest degree of dependency. For example, in Portugal, Santa Casa, the major provider of services, has a classification system according to vulnerability criteria. Second, the people that are most isolated. And the third criterion is the people that went to daycare centers, but because those centers have been closed down, they are missing those services. For example, in Galicia, in Spain, the daycare centers have been substituted with a special home service. Now, what tasks have received priority? First of all, care and personal hygiene, medication, buying and preparing food, and also there has been a reinforcement in phone calls and also in distribution of food to their homes. For example, in Madrid, according to Bienestar Social, that service has been increased by 23%. Now, if we move to the next slide, despite all of the services being provided, as you can well imagine, there have been some important needs. For example, there is a lack of personal protective gear and also a lack of diagnostic materials in most countries. Also, a lot of the users have decreased. The number of social services in Italy tell us in many cases the users or their families have asked to not use the service because they're afraid of contagion. And also, they talked about a lack of staff. For example, in Sweden, they reported that one of the major problems is absence of their staff. And in part, that's because they are afraid of contagion. Now, how have they tried to deal with these situations? First of all, an economic effort has been made to provide protective gear. Also, teams have been reorganized to cover both personal care and telephone care. An economic effort has been made to agree with the providers of the services for payment for services not delivered and also psychological support to workers. One major thing in Europe has been the availability and the use of PPE. In the UK, a social service provider said that the cost for social services to get PPE for those people providing home care is higher in the health arena. That is because the National Health Service has a national system for PPE distribution, but that is not the case for social services. So for them to be able to get PPE from the suppliers, this is much harder and more costly. Now, to deal with that problem in France, for example, the social services departments in counties work along with regional health services to assure the access to and distribution of PPEs. Also, they send a weekly questionnaire to vendors so as to find how many people have a dependency, how many people are at the risk of losing the service. In Sweden, there are specific care units for COVID cases or those that have been discharged from hospitals. Now, if we can move to the next slide, there is a second question, and it had to do with how you can guarantee the participation of professional associations and services in providing this care. These services are provided by local social services directly, or in most cases through entities that are service providers. That is either home service companies or authorized social initiative entities. For example, in Madrid, contracts are a public bidding process, and measures have been taken, as I explained already, so that the providers of services will not be in such an unfavorable position in terms of acquiring PPE. In France, local authorities guarantee home care through individual assistance plans for each beneficiary. And in Belgium and Italy, they do not control the provision of services, but they act more as mediators, as intermediaries. In Belgium and Italy, in addition to regular services, they have also reached an agreement with volunteer associations, the Red Cross, for example, to guarantee distribution of food, medication, or different social needs. Now, on this next slide, we respond to the third question. It has to do with remote assistance and its reinforcement during the crisis. Basically, we have seen that the remote assistance service has been reinforced via phone calls, SMEs, also the possibility of just pushing a button, creating an alert. Unfortunately, this service is not broadly based. Now, in Belgium, distance service has been provided through SMSs or telephone calls. In England, they have a preventive call system on the part of professionals, or also reactions to a button call, or they have delivered tablets to people that have support from social services. In France, financing home remote services has extended, but it's still not evenly distributed amongst all departments. However, in France and Haute-Garonne, they are financing remote assistance devices for all people that are dependent, all the people that they're responsible for. Now, two examples from Barcelona, where in Barcelona they have a coverage of 12.5% to those over the age of 65 and almost 40% for those over 80. Plus, there has been a reinforcement of teens to detect risk. That would be smoke, gas in the home place. Also, they have reinforced their services. For example, by setting up a professional service, they have seen an increase in the number of users because of uh, fragility, dependency. In Madrid, the second case, 145,000 people are cared for by a remote assistance service from the social welfare department, and they have an assessment of their risk. Also in Madrid, they have reinforced remote assistance with new services, one psychological support in cases of grieving, or for people over the age of 68 to 75 that do not have municipal services. They have reinforced the phone calls to that population. Now, to conclude, because I see that Lourdes is looking my way, just to conclude, I wanted to say that we need to look to the future. In emergency situations, like what we are currently experiencing, we need four things, at least four. To begin with, we need to reinforce our home care model. We have to rethink the model, moving from an institutional model to a model that is home-centered. This affects not only the services for seniors or people who are dependent. This has to be reinforced right from childhood because our expectations come from our childhood in terms of people who have a dependency or who are older. So we have to reinforce the idea of home-centeredness. We have to also assess the quality of care. We have to center on improving the well-being of the people we protect. Also, we have to reinforce the means that allow implementing the model using, for example, technological measures to support living at home. And lastly, we have to consider this sector as essential. And the access has to be one of equal conditions to PPE or the necessary materials. It's important that they have good access to protective equipment so the professionals can do their job with all of the necessary guarantees and in a secure environment. Thank you. Thank you. Thank you very much for your efforts, and thank you very much. And now we are going to have the opportunity to hear from 3 different people. But first, I wanted to remind you of the 3 questions behind our discussion today. Here, I am thinking of all of you who are with us. Send us your questions through the chat. First of all, the first question is, how can we guarantee continuity of services of home care? What is the logic behind that care? And what criteria do you apply to prioritize this care? The second question is, how do associations, entities help guarantee the service? And lastly, the last question is, how are you using remote assistance services? So now I'm going to call on Elisa Mendoza, who is a specialist from the long care centers. And before I call on Elisa Mendoza, I wanted to remind you that these panelists have a maximum of 5 minutes. So I will remind you once you reach 4 minutes of speaking. Elisa, you have the floor. Thank you very much for your invitation. This is an interesting opportunity to be able to share with you what is happening here in France. I will turn to very concrete things because in listening to Alfonso Lara, that is an interesting bridge. A lot of things were already said, but perhaps I should tell you a bit about the current context in France and in Europe, just some hard data so you can see the impact of COVID in caring for the elderly. 25% of the population in France is over the age of 60. And between now and 2050, 1 person out of 3 will be over that age, the age of 60. 1.5 million people right now benefit from rudimentary care for dependency. That means that these are people that are highly dependent and they are in institutions or long-term residences. And more than half of them are there, and the others receive home care. 69% of these highly dependent individuals are in institutions. This 19% are in institutions, and most of the people are in home, and they're not entirely dependent. So as Alfonso Lara was saying, one of the things that continue to be tremendously important is home support because of 2 basic challenges. The first one was mentioned quickly, having to do with social isolation and loneliness. In France, people over the age of 60 may live alone. That's a big challenge without thinking of the differences across regions. It's not the same to be elderly in a big city as it is to be elderly in a rural environment. 300,000 people can be considered to be socially dead in France. That means no contacts. Now, regarding solutions and how support services are organized, there is a tradition that has to do with the hospital and medical care, different institutions, also uh, centers for the elderly. And now there are 4 million people in France that work with the elderly in their homes. Only 8% of these people live in that same place. So we see a lot of the older adults living in a situation where there is both social and family fracture. So there is a big challenge in dealing with that. Now, what happened with COVID is, and this is reflecting the big impact that exists in terms of how hard it is to provide daily support, especially for those that are highly dependent. 1/3 of total deaths in the country come from those people that are highly dependent. So very hard for the people working in the institution. And regarding the people that work in these homes, what Alfonso Lara said is true here too, regarding the need to have the necessary protective equipment to deliver these services in the home. Now, some institutional actors recommended that we delegate tasks amongst professionals and that be at the institutional level. And those that deliver these services, there are different people, sometimes family members, other times it's professionals that render these services. And it's important that we prioritize the intervention of all professionals. Another thing that was done in this case as part of the emergency is to have real-time sharing of information. That is because we have platforms to assess the emergency, and then we have response time platforms. Or, for example, we have helped create platforms that provide for the interaction of different players. Elisa, I apologize, but yes, I'll go through this very, very fast because in talking about remote assistance, this is very interesting, but you have to take into account the number breakdown here in France, where there is no access to an internet connection for a lot of the older adults. So without the support of family members in the home, these elderly people may have access to activities through numeric information, but it's hard to assure that that will actually be the case. Now, another very interesting thing we have been following is all of the initiatives that COVID has provided. There is an opening up of different social interactions to fight loneliness and also to support cognitive function through workshops, etc. There is a whole gamut of initiatives that have been prepared here in France. And just, I'm sorry, Elisa, I need you to wrap up. Yes, 226 different initiatives exist right now. But the interesting thing is that later on, we will have to assess exactly what the impact was, if they were made use of, what was the benefit of all these initiatives that surfaced to keep the social contacts in France going. Thank you very much for your contributions.
Thank you very much for your support, Elisa. And I'd like to move on to Octavio Vergara, director of the Cinema from Chile, and ask him to discuss the Chilean experience with us. Thank you very much, Lourdes. And I also wanted to thank Eurosocial and the Inter-American Development Bank and all of my colleague panelists for joining us in this very important webinar. I'd like to speak to the reality that we see day to day in Chile. 20% of our population at the present time is 60 years of age or older. Of that population, 15% have a physical or other type of dependency. Something that's particularly worrisome in this context relates to people 75 years or older who show a very high degree of vulnerability, who also live by themselves and show a very high dependency. So we have approximately 40,000 people that fall under that category. So in our government, we've tried to maintain continuity in the care services, and we're also trying to redirect other programs towards the home care arena. We have some measures that have been geared to people 75 years of age or older in the entire country. So we've increased, or rather we've limited home visits to only the most critical cases, given that the need for in-person home care, given the present conditions due to COVID, are very difficult. And so we've been trying to maintain the standards recommended by the authorities to ensure that there is no contagion between the service provider and the service user. Who has been reinforcing these home care situations? Well, these are primarily geared to people who show a high degree of risk, who live in isolation. But we've also reinforced through these programs our Telecare follow-up mechanism, and we've extended these services to users, and we've also redirected other programs that were working in other areas and redirecting them towards this effort to supplement the existing system. So we had a day center service that provides activity services for users, and we redirected this program's mandate to supplement the effort being done on the home care front. So people no longer have to go to these activity centers, but rather we're trying to extend these activity centers to the homes. Another thing that we're doing has to do with providing support for these home care services through the delivery of medication and food boxes. This is something that was mentioned in the president's speech yesterday. How do professional associations and entities participate in these services? Well, all of the institutions, be they public or private or nonprofit, they all work with our national authorities, and they have to be a part of a registry as accredited service providers. And they also have to accredit the experience and the qualifications for their staff. So this is a new possibility that allows us to expand the effort, but it also allows us to call for greater community support. So we're undertaking a campaign called You Can Count on Me, and it seeks to create outreach in all the communities so that the community members can take an active role in supporting some of these services for these people who are deemed to be high risk. Something else that we've been working on relates to connecting telecare services. And so first and foremost, we assess the needs in the homes, and we work hand in hand with local municipalities, local communities in delivering some of these services to those people who need it the most. Additionally, we've been working with the private sector and with MedLife and other companies on a telecare system that is called Telelinks, and they've set up 4 centers nationwide providing services to the elderly, and they have an application that serves as a panic button that they can use on their phone. And so it allows them, through the press of a button on their phone, to have immediate contact with a person that can provide services, many of them clinical. And so that's been the overall comprehensive strategy that we've been using with regard to home care services. We've expanded the program, redirected other programs, called for the community to support us in this regard, and created these various telecare centers. Thank you very much. Thank you for being so brief, Octavio. I didn't even need to interrupt you to close with your remarks, so thank you. Next we have Beatriz Garcia, Director General of the Dignified Aging Institute in Mexico City. You have the floor, Beatriz. Thank you very much. Good morning to all of you. Our Dignified Aging Institute is a reflection of the condition that our elderly have in Mexico City. As a result of the COVID pandemic, we've had to reinforce the services that we provide. The daily labor of home visits that require thousands of caregivers now has been converted to telecare services that would provide for more than 525,000 people, many of them members of the elderly class. We try to ascertain what their conditions are and provide services in whatever way we can. Additionally, we've been supporting food delivery services with the support of the federal government. Of those 525,000 people, about 350,000 of them have a telephone, and those are the people that we are providing daily follow-up services for twice a week. Given that this is one of the most vulnerable groups in the face of the pandemic, we've implemented our support system for elderly people that don't have access to the support network, a social security network. And we've undertaken a number of activities on a daily basis. We've provided a telephone number for more than 570 people. These are cases of people that live by themselves. They are 70 years of age or older. They have no access to social services, and they also show signs of disease. The care afforded to these people includes the delivery of free medication in their homes. We provide food aid. We also provide care throughout the emergency so that they don't feel alone and abandoned. And we try to ensure that there's no emotional deterioration. Part of the service includes doing different tasks that allow them to remain at home. The team, of course, complies with all of the necessary standards to ensure that there's no infection that takes place during the home care services provision. We handle more than 5,000 calls for people who live alone in the home, and we conduct more than 500 visits to homes per day. We have delivered more than 700 medications to people who do not receive them through any health organization. Additionally, we continue providing care, taking into account cases of abuse and violence that, as we all know, has been on the increase as a result of the lockdown and the self-quarantine. And we've also undertaken a number of activities to intervene in those cases where this type of activity is detected. We've also created a platform for volunteer students that provide care to older adults, and they are a part of the mutual support network of our institute. We're trying to promote a greater interaction and greater degrees of contact on an intergenerational level Most of this work is done through Telecare services, but a lot of these visits are done in person. We also have Telecare through our Citizen Council of Mexico City, and we have a phone line available for people whereby we can provide psychological and legal support to people who belong to the elderly population in the Mexico City. Additionally, we have 230 different learning circles, and these are circles that are coordinated by professionals. And in a remote way, we conduct activities to help ensure that these people maintain their physical conditioning. We also do remote conferences whenever possible. And we've also implemented a number of other activities that people can undertake in the virtual setting with the support of their family members, be they grandchildren or children. Forgive me, but we need you to wrap up, please. So these are the basic actions that we've been implementing at the Institute, and we are part of the Social Development and Social Inclusion Secretariat. Thank you. Well, thank you very much. And I'd like to thank all three panelists. And we have now reached the moment for us to open the floor and have a discussion and perhaps answer some questions that we've been collecting through the chat stream, and we can direct them to the various panelists. So we will proceed to check these questions. There's one that is directed to Juan Luis Bermudez from Costa Rica. Undoubtedly, one of the more difficult issues in approaching healthcare and telecare issues or services relates to the coordination among institutions, and more concretely, social, or the coordination between the social and the health arenas. And so there are strategies that could perhaps capitalize on the resources and the available tools that are available. And so I'd like to ask, as part of your initiative, what types of services have you been able to capitalize on? Can you also give us some examples of this cross-sectoral interaction? Well, the coordination in our countries and in our sectors is not something that happens spontaneously. It's actually quite painful, but we need to tolerate that pain. In our case, we have a risk evaluation system that has allowed us to change the organization that we work with typically in a cross-sectoral way, and we would do so under conditions of peace. Now, all of this depends on the institutions, both of the health sector as well as the social sector. And we to include all of these in the task force. So we have a number of agencies that exist in all countries, but in this task force, we have the intervention of various representations and various ministries and organizations. But one of the key items has been the social information systems. And this allows us to very quickly change standards related to risk factors, social factors, epidemiological factors that affect, in particular, the elderly population. And so we can then create innovative methods to address these issues, but much of the decision-making has been made on an evidence-based system, and this has been very effective. And I see this as one of the opportunities that has been created by the pandemic. And I would say that we may have had networks at the local level established prior to the pandemic, and these are networks that can be our strategic partners, not only as receivers of these standards and measures that we are recommending, but in many cases, they can be the source of feedback that can serve to nourish our programs that will allow us to address a growing demand, especially in high-risk populations. Well, thank you very much. It's clear that the coordination that we're referring to does not just refer to social and health coordination, but it's also sometimes involving the difficult coordination between national, state, and local governments, as well as different local communities, as well as other organizations that exist in different settlements or rural areas. And so in order to really reach all citizens, we see a very clear-cut challenge in this regard. I'd like to ask Viviana and Patricia Jara from Chile for submitting their question. Next, we have a question directed to Daniel Radío regarding Uruguay. We talk about contingencies or emergencies, and we discuss families or people that need care and that don't have access to a personal assistant. Have you developed any contingency system to at least provide palliative care? Or as these circumstances have been arising, have you been able to come up with a response for this situation? The truth is we haven't been able to address that issue, and this is one of the things that has perplexed us the most. Again, what happens in our system is that we have a number of private entities, and we need to achieve some semblance of coordination among them. So clearly we have a responsibility, but we also have to face that this is a very complex situation in the midst of this crisis, and we haven't come forward with a response, an adequate response for this challenge. Thank you very much. There's another area that I believe is very relevant, and it's being mentioned by Pablo Ibarra Barragan y Laura Iberi. And I was also very interested in asking you about the specific training that is provided to personal assistants or caregiver professionals or care providers. And I'd like to ask the question to Luis, Daniel, or Alfonso Lara, what concepts or what specific practices or competencies apologies from the interpretation booth, the signal from the speaker has been interrupted. Hello, Lourdes, we lost your audio and your video. Can you please repeat your question? I think that Lourdes's connection was interrupted. So I will relieve her until she can log back into the meeting. Daniel, I think that the question that was being posed by Lourdes referred to the issue related to human resources. What type of specific training has been conducted in the different countries? Daniel, can you share a little bit about the experience that you have in Uruguay if there's any special training being provided to service or care providers or caregivers at the present time that was deemed to be particularly important during this time of the pandemic. And I'd also like to ask the other panelists to discuss some of the efforts undertaken with regard to training personnel. Thank you. Well, I think that the population that makes up the personal assistant staff is an extension of our caregiving system. Our caregiving system derives from a public policy that seeks to improve the quality of life of the affected populations, and it also wants to improve the quality of life of the providers. So one of the key elements is information, and we have an agreement with training organizations that provide support to us as well as financing to be able to conduct training both in the public and in the private sectors. And they conduct workshops to provide training for providers so people can come out of these workshops as certified caregivers, and then they can subsequently move on to work as personal assistants. But given the current crisis, we've been reinforcing this particular initiative through volunteer workshops, and this has been managed from the Ministry of Health. And this isn't just part of one single ministry. A number of ministries have taken part in these training mechanisms and have provided workshops to train personnel with a special emphasis on health matters. And we have certainly prioritized those people that seek to work as personal assistants as well. I don't know if my answer was satisfactory. Of course it was. And I would then like to ask Minister Juan Luis Bermudez to share some insights about the same thing in Costa Rica, please. Thank you, Marco. Well, along the same lines that Daniel was talking about, as a country, we have an emerging market, and I'm talking about training for health care providers. And we have training available in our ministry, the health ministry, and they trained professional staff. But given the emergency that we are now facing, we've seen the development of the possibility of putting together curricula and different types of material that would allow us to address emerging demands. One of the realities is that we've had to change much of what we do. And so in order to have an adequate integration for staff that involves health workers, be they nurses or technical health professionals, and we refer to them as primary care technicians. And this has been vital to our efforts. And given that we are engaged in social distancing practices, we've seen that through the use of their own mobile phones, smartphones, we can quickly disseminate information related to confirmed cases or suspicious cases. And this has been a tremendous support for our health system. But we haven't seen any other way in which we could have reached such a broad spectrum of personnel other than this one, and this has been truly productive, especially in the face of this pandemic. Thank you very much. Octavio, if you please, could you discuss how you have reformed the various tasks provided to locations where communication is very difficult? Well, that's a huge challenge that we have as a country, especially when we understand the geography that Chile has. all across our territory. And it is the elderly that ends up living by themselves, and the younger people tend to migrate to the large urban centers. And so there's a tremendous challenge in that regard, not only related to the pandemic, but from a service provision standpoint, we've been facing these challenges for some time. And we've been trying to gear our programs with a special focus to those areas. And as a result of the pandemic, these have garnered ever more importance. And so as part of our coverage and the intensity of the coverage, we're trying to reinforce these home care service provision mechanisms and extend them. And so we partner with other local actors, and these are partnerships, strategic partnerships that we've been trying to undertake with local and regional organizations. We've also used media to try to help our efforts. So our strategy has been to grow and extend our program to these areas that have not received these services, and we've tried to provide coverage for a lot of these areas where the service provision is precarious or uncertain. And we've also tried to work with other organizations that have been key actors. These are organizations that have worked with the elderly prior to the pandemic. They understand the reality that each person is living in their respective rural locations, and they understand not only the conditions, but the culture, and the work that they have done in collaboration with us has been tremendous. Thank you, Octavio. I have a question for Beatriz Garcia. A very important topic that's been discussed that relates to social distancing and the increase that we've seen in domestic violence cases, and in particular, incidents of violence towards women. This provision of services in the home can be a key element, especially given these high rates of domestic violence. Can you discuss a little bit about what you're doing in this regard? Yes, of course. We do home interventions along with the district attorney's office, as well as victims advocates organizations, as well as the gerontology and geriatrics unit in the Institute. And so when a claim is made or when there's a report made, we try to have a discussion with the family to ascertain what the facts are on the ground. We try to speak in private with the older person prior to speaking with the family to see what the person requires. If they want to make a report or file a report, this can get pretty complicated because by and large, the violence comes from their children or their grandchildren. So when these older people try to file a formal report with the local authorities, then we try to conduct a conciliation intervention that involves all the parties. We obviously provide directed follow-up in each specific case until such a time that we can perhaps try and unify the family once again. Thank you, Beatriz. I think Lourdes was able to join the meeting once again, so I yield the floor back to her. Yes, thank you so much, Marco. Apologies to everyone, but we had blackout, and as you all know, we are all highly dependent people, and we depend on technology. Clearly, a great deal of the caregiving effort is focused on women, or is provided by women. Most of the caregivers or service providers are women. And I'd like to ask any of the panelists, have you seen any examples of redistribution of tasks or something of that nature that can serve to avoid having the burden fall on the usual people that take on the burden traditionally? Is this something being done at the organizational level?
Perhaps there has been some restructuring or advice given to the population so that they can share tasks at home to assure a better balance at home in the families. Yes, in Mexico City, we have implemented some infographics saying that care needs to be provided by everyone, that we're all responsible for our older population. Also, we have put recommendations, advice on the networks saying that not only should women be caregivers. Yes. Also, to respond to Lourdes's question, in our countries, there's definitely a situation where we have to make certain that women join our workforce. And that has to do with the unfair historical workload that as a society we have given to women, where women are major caregivers. And what we see is that in the situation where here, what we're seeing in Costa Rica is that because of limited household income, we see more and more women joining the workforce. Now, we as a country continue to support the universalization of childhood development for both boys and girls, but we still have a major challenge, which is to have a system to provide care so that we can take care of our elderly population, people that are disabled, that require long-term care. And so this pandemic puts this back on the table. Now we have made an important appeal. We don't want the care for children to be left in the hands of the elderly, which sometimes occurs. So often we see that the elderly provide for grandsons, granddaughters. So it's an additional responsibility as part of the life cycle. And that has to be viewed from a standpoint of co-responsibility, looking at the elderly, but also looking at society as a whole. Now, this definitely calls for a redefinition of roles within the household. This is positive, but it needs to be reinforced with institutional changes too. I would like to say something too. I wanted to say that this is a good time to not be complacent and to realize what the shortcomings of our systems are. Now, in our care systems, how is the social division of labor having an impact? That is something that is a backdrop of this whole discussion. And I think that we have to constantly monitor and hopefully measure this. For example, looking at the use of time. Almost all of the responses that we have tested are vulnerable to basic cultural concerns or things having to do with a wage gap every time that you provide a subsidy that could be choosing the mother or the father as caregiver. Because of salary gaps, it's always the woman that gets to take care of the children. So we need to monitor this and hopefully measure it. One thing that we have to wonder about constantly is what is the real impact of our system on the sexual distribution of labor? Thank you. Thank you, Daniel. I wanted to thank everyone else. The truth is, this is a handicap that exists in many societies. Here in Europe, this occurs too, and often we don't even have the sensitivity to remind everyone that everyone needs to be providing care because we are all dependent and codependent. So we all need to care for others. There's another interesting question. It is, how do we approach differential care with different ethnic communities, for example, indigenous communities in different countries? And this is something that can be tied to the rural housing, the remote location of many populations. So my question is, how do you approach this care in ethnically diverse communities or locations? Well, in the case of our Institute of Care for the Elderly, we have 525,000 people that we care for. And then also we have 823,000 elderly working with Mexican government. Now that includes the indigenous community where we have older people living in rural communities. So we do have visits to their homes on a regular basis. We visit everyone in Mexico City, including those people. Now, if they have no phone, we call on them at home. And now, in the case of these persons, we have asked that some neighbor, some family member give us some contact phone so that we can keep in touch with those people. That's what I can tell you about Mexico. Here too, after Beatriz, I turn to Lourdes's question. Now, in the case of Costa Rica, we have had, and this is an ethical uh, dimension too, but we have taken into account the ethnic differences. Now, there are four actions, that is prevention, visit. Here I'm talking about indigenous populations. We have an approach of suspicious cases, confirmed cases, and it's clear that working with local organizations, especially the local emergency committees, has been important. We in our administrative division have provinces, and then a smaller unit is the canton. Now, we do have emergency committees in each canton where we have participation of the indigenous communities. We can provide care, especially in terms of humanitarian assistance. Here I'm thinking of providing food, for example, to a population where their supply chain has been interrupted because of the economic slowdown or because of some border measures that have been implemented. So we have to work with local community organizations. Also, we have to work with other players that take care of the elderly. This is at the canton level throughout the country. So we have been able to have a culturally appropriate action where we work with those over the age of 80, people who live alone in conditions of poverty and that have socioeconomic needs. Priority two, those under the age of 60 with an aggravating factor that is part of the epidemiological profile, people that have needs but who have some sort of support, someone from their family. And then people over the age of 60 with without them having a socioeconomic vulnerable condition, but nonetheless, we provide them with follow-up. So we have a triage system and we have a stoplight system, green, yellow, red. Well, Juan Luis, the truth is that grouping, that prioritization will identifies one of the needs that has emerged now that we are looking for solutions, where we have to pinpoint who is vulnerable because of a physical health condition, because of dependency, or because of economic reasons, or inclusion, or poverty. And then following up on that, you define what your intervention is going to be like. So that is a learning experience, and it's good that we share it. Something else that came out in the initial round of remarks has to do with psychological support and how we can minimize the psychological impact on the elderly in this situation of COVID, especially in terms of isolation as well as subsequent opening up and interaction with the community. So I would ask our panelists, do you want to talk about strategies for psychological support and also to deal with the fears that have been experienced by many of the elderly individuals as a result of this pandemic? Lourdes, I would like to tell you about what we have done. Yes, we have a phone line uh, free of charge. And there, the idea is to provide emotional support to these older adults. This complements other programs. And the truth is, it has paid off. This is a line that was not devoted only to this purpose. It used to receive 12 to 15 calls a day, and now it's close to 1,000. So a lot of this has to do with emotional response. What we did in this service was we trained our staff. Many people in Sinama, for example, cannot be out there visiting homes. They can't do their usual daily tasks. So we have trained those people, and they are playing an active role answering these calls. Many of these people talk to the callers. We can provide more specific assistance over the phone and also with the uh, civil defense. We have some psychiatrists, psychologists who are helping us. And if we need to consult a specialist, we have worked with other institutions that are involved in mental health for the elderly. And that joint effort has really been something that has helped us a lot to deal with this pressing need for emotional, psychological support of these people who are confined to their homes. Yes, that's very interesting. Perhaps in view of a need, we see that initiatives have come from the public administration. That would be the mental health services, social services, or in other cases, the initiatives has been taken by professional associations or other more private concerns. They're the ones that have developed hotlines, but not with the support of the public administration. Here in Spain, we see that the support has come more from professional organizations, more informal networks, and it's really something where we see that not everyone has given equal importance to mental health. It's interesting to see how there are different arrangements to support mental health. Now, there's another question that we have been receiving. Thinking of evaluating the effect of stress and emotional functioning with function. For example, nutritional evaluation in older adults. Do you have any experience in this connection? Lourdes, I wanted to add to what you said right at the end. In the case of Costa Rica, we have set up a line for COVID in general, and it's for the population, but it is the Association of Psychologists. They are the ones that offered us the possibility of us transferring calls to them. And in that way, they can address emergencies. Now, in terms of specifics, we have seen that there has been variation in cases. There has been an increase in very specific acute cases where there is a manifestation of stress. There is a problem with controlling high blood pressure. So somehow the lockdown, the social distancing is having a direct impact on conditions that existed previously in these older adults. And because of that, we have had to step up preventive services as well as our response services. Close to my house, just to give you a personal example, an older person had to receive a response from the Red Cross. That person had a panic attack because that person had been isolated for several weeks. And I think that for us, it is premature for us to assess or measure the impact, despite all of the efforts that have been made. It would be irresponsible to say there will be no impact. These extraordinary circumstances will definitely have an impact on health. We don't know if this will only in the short or medium term. But what we have to do as institutions is we have to plan on how we're going to measure that impact and how we're going to take this into account, not only in terms of dealing with this current emergency, but also by formulating differential strategies for the future. Thank you. It's true that the impact, the suffering is going to be there. And we need the cooperation, the collaboration of everyone, formal, informal, community service, so that we can identify the impact not only on the elderly, but also the people that provide personal assistance services in the home or remotely. We have one final question. Unfortunately, we are short on time. And this question goes to Daniel Radío or Alfonso Lara. The question has to do with the cost efficiency of remote assistance. And also, what is the coverage right now? What is the coverage of remote assistance in your countries? Please go ahead. Please go ahead. Okay. Well, briefly, we don't have any specific study of remote assistance, but it is true that what we have seen is that countries deal with home care or remote assistance services in different circumstances, culturally or because of cost efficiency reasons. For example, in early February, we visited the Diputación of Barcelona, and they told us about how they have expanded remote assistance, and it's because of the cost of providing home services. So remote assistance for them is a service that is more cost efficient, and consequently, they have been investing in it. Whereas in the case of Northern European countries, that would be the Nordic countries, Sweden, there the coverage of home care can reach 30%. And as the population ages and as it becomes more difficult to reach certain zones, for example, right now we were talking about reaching rural areas. In the case of Nordic countries, they have people living in rural areas far away, and it's hard to reach everyone. And because of that, there's a situation where they're investing more and more in remote assistance from a very broad perspective. In other words, not only if there is an alert, but also they use fire detection, fall prevention, other sorts of devices, because with remote assistance, we can provide different remote types of care to help these people at home. to be there more effectively. Obviously, what we have to do is to try to have a broad-based approach that would include both things. In other words, having personal assistance, but also the remote assistance support. Well, thank you. Thank you, Alfonso, for your contribution. And I have to wrap the session up because we are short on time. I have three things that I want to say that I think sum up the three ideas that are takeaway lessons. First of all, to guarantee the continuity and the quality of care, the cooperation, the coordination of care for the central administrations and countries, and also with the municipalities, smaller towns and villages, and also the support systems and support mechanisms, formal and informal, counting on the support of the community. So all of that has to be coordinated. Of course, it's priority to identify people at risk so that we can focus on them and we can focus our efforts in the direction. We have to learn from what we have done right, what is here to stay, so that once the pandemic is over, we have to keep the valuable things in effect, and all of the networks, all of the cooperation modalities that we devise now will help boost all of the work that we need to do. So as we said at the outset, we cannot be self-complacent. We have to continue to prepare, to continue to learn and share our learnings with others. Thank you. And I now turn the floor over to Virginia Tedeki. Good morning or good afternoon. First of all, I want to thank all the speakers. Everyone continues to try to support different care systems. Also, we wanted to thank all participants for their active contributions to the chat. We have reached almost 300 participants, and I wanted to thank Lourdes for moderating the session. This webinar on the continuity of care at home and remote assistance services to people, as we have said, this is a coordinated effort by the IDB, CISCA, Eurosocial, and we hope to be able to continue to promote this cooperation. We need to jointly reflect on concrete practices, which is the DNA of this program. Initiatives that are person-centered so that care will not only be placed on the shoulders of women. We dealt with many different issues today. All of them are very relevant. I don't want to take too much time, but I do want to mention, first of all, the pandemic that is similar across all countries, but the timing, the responses have been different. And that means that we can share challenges and solutions. Governments have had to quickly and creatively find different ways of responding to the needs of people that are elderly. They have had to interact with different sectors of society. The relevance of coordinating different areas of government to deal with a crisis. That is something that opens up interinstitutional spaces. Minister Bermudez from Costa Rica talked about a comprehensive committee to deal with the needs of the elderly. Also, they talked about the need of the elderly, the care they need, and the importance of coordinating with other organizations to deal with situations of violence, as was mentioned by Ms. Garcia from Mexico. Also, another important thing is using additional channels for prevention and to address the specific needs of the elderly. So we can use radio stations, we can use different mechanisms to send out messages that are elderly appropriate. Something else that came out is using existing problems for home assistance. And here I wanted to say quickly that appropriate training measures have been taken, not only to provide material to avoid contagion, but also to mitigate the impact of physical distancing. Everything that Uruguay and Chile raised about helping people that visit homes, also providing support in rural or remote areas. Then we covered many, many different difficulties in terms of providing services in the home. They talked about some services where people have refused the service to avoid contagion, different mechanisms that were adapted to coordinate services. And this brings me back to telephone care, psychological support to workers. Another pending matter raised by Lara had to do with considering in all countries that we have to see these workers as part of the official sector. So I could go on and on. I don't want to use up any more time, but the important thing is that this whole situation means that we have to reassess current systems. We have to amend our care models and also take evaluation into account. Eurosocial has been acting in different areas. We have been working with the European Union on actions that you can find on our web page. This webinar is part of our regional efforts, and this is coordinated with different institutions that are in charge of care. We will continue to work, perhaps in June, we will be working on an upcoming webinar. And once again, I wanted to thank all participants, those from the IDB, CISCA, to continue to develop this joint effort, placing emphasis on the people that require care and also the people that provide that care. Thank you, Virginia. I wanted to thank everyone. Please do check the material and the resources on COVID-19 and the older adult on the Panorama of Aging and Dependency. Also, it's on Eurosocial's web page. And in the next few days, we will send you information on how you can tap into the recording of the seminar. We will include the materials on the Panorama webpage. We also invite you to download a recent publication called Aging with Care. That is something that is on our webpage. On June 16th, there will be another seminar on human resources. Who provides the care? How can we develop human resources and provide social protection to care for dependency? That will be in cooperation with Cooperation for Development. Also, we will be working with the French Development Agency and CISCA. We will keep you abreast of all of the webinars. We will send you emails, and also this will be on Panorama's website. I wanted to thank all of the teams from the Inter-American Development Bank, Diego Vapore, Soledad Planes, Sandra Iriarte, Enrique, Sol Sasadrid, Alfonso Martinez, Carlos Soto, the people from Eurosocial, Andrea Monaco, Sofia Chiaducci, our colleagues from CISCA, and the colleagues from AFD, Diego Vapore, Soledad Planes, Sandra Iriarte, Lice Manrique, Sol Sasatornil. I wanted to thank all of you again. I hope that you enjoyed the webinar, and goodbye. Goodbye. Thank you.